This is Dr. Charles Schwartz from NYU School of Medicine discussing mitral stenosis. Rheumatic heart disease is the most common cause of mitral stenosis or mixed stenosis and insufficiency, although a definite clinical history can be obtained in only 50% of patients. The etiologic agent is most commonly group A beta-hemolytic streptococcus. It is often a pancarditis affecting the myocardium, pericardium, and endocardium. The female-to-male ratio is 3:1. Congenital valve deformities also do occur, however they are rarely seen in adults. Mitral annular calcification and endocarditis are also etiologies of mitral stenosis. Intracardiac tumors may obstruct the mitral orifice and cause symptoms that mimic mitral stenosis. The pathology of mitral stenosis is a progressive fibrosis with 3 distinct degrees of pathologic change: fusion of the commissures alone, commissural fusion plus subvalvular shortening of the chordae tendineae, extensive fixation of the valve and subvalvular apparatus with calcification and scarring of both leaflets and chordae. The degree of pathology present should be determined preoperatively. This predicts the suitability of balloon valvuloplasty, surgical commissurotomy, or valve replacement. This is a picture of a classic rheumatic mitral valve, featuring fused commissures, thickened anterior and posterior leaflets, and scarring. This is also a rheumatic mitral valve, showing thickened leaflets and shortened chordae tendineae. Mitral stenosis most commonly has a prolonged course. Symptoms may not appear for 10 to 20 years. Mitral stenosis leads to a progressive decrease in the mitral valve area, which results in a transvalvular gradient across the stenotic valve during diastole. The left ventricle remains small and non-compliant. The normal cross-sectional area of the mitral valve is 4 to 6 square centimeters. Symptoms may progressively develop with moderate stenosis, defined as a cross-sectional area of 1 to 1.5 square centimeters. The left atrial pressure remains 15 to 20 millimeters of mercury at rest. Severe symptomatic stenosis occurs when the mitral valve area is less than 0.8 to 1.0 square centimeters. The elevation in left atrial pressure produces pulmonary venous congestion and pulmonary hypertension. As the left atrium dilates, atrial fibrillation may develop, exacerbating the patient's symptoms. This may decrease cardiac output by approximately 20%, precipitating acute pulmonary edema. This increases the likelihood of clot formation and embolization. Left ventricular function, however, usually remains normal. Irreversible increases in pulmonary vascular resistance may occur, and there may be an inability to increase cardiac output upon demand. Mitral stenosis is a continuous, progressive, lifelong disease. There may be a slow, stable early course, and a latent period of 20 to 40 years from rheumatic fever to the onset of symptoms. The onset of symptoms to eventual disability may be 10 years. Atrial fibrillation may occur in 30 to 40% of patients and is more common in older patients. The overall 10-year survival for mitral stenosis is 50 to 60%. Asymptomatic patients have an 80% 10-year survival, with 60% of these patients having no progression of symptoms. In symptomatic patients, it is 0 to 15%. Patients with severe pulmonary hypertension, less than 3%. Older patients with atrial fibrillation, 25%. And patients who remain in normal sinus rhythm, 46%. The cause of death for patients with mitral stenosis is congestive heart failure in 60 to 70% of patients, systemic embolism 20 to 30% of patients, pulmonary embolism 10%, and infection less than 5%. The acute symptoms of mitral stenosis include exertional dyspnea and decreased exercise capacity, dyspnea from pulmonary congestion, orthopnea and paroxysmal nocturnal dyspnea, hemoptysis in severe cases, and the most serious development is pulmonary edema. Chronic symptoms include pulmonary hypertension, right-sided heart failure, jugular venous distension, hepatomegaly, ascites, or ankle edema. Atrial fibrillation develops in a significant number of patients. These patients may decompensate. Atrial thrombi result from dilatation and stasis in the left atrium. Cardiac cachexia may occur. The auscultatory triad is a loud first heart sound, opening snap, and apical diastolic rumble. The EKG in mitral stenosis may show atrial fibrillation, left atrial enlargement, and right axis deviation. The chest X-ray will show left atrial enlargement on a postero-anterior film, seen as a double contour visible behind the right atrial shadow. Left atrial enlargement and the pulmonary artery may obliterate the normal concavity between the aorta and the left ventricle, producing a straight left heart border. Mitral valve calcification may be seen in addition to alveolar edema. The echocardiogram is diagnostic. It measures the transvalvular gradient and the cross-sectional area of the mitral valve. Exercise echocardiography may be used to determine if a significant increase in the transvalvular gradient and a rise in pulmonary artery pressure occurs. Transesophageal echocardiography is also important. It provides an unobstructed visualization of the mitral valve and the posterior cardiac structures. It provides an assessment of the degree of leaflet mobility, calcification, and subvalvular fusion. Cardiac catheterization is also important in the diagnosis. One may calculate the mitral valve area with the Gorlin formula. The normal valve area is 4 to 5 square centimeters. Symptomatic patients, it is 1.4 to 2.5 square centimeters. And in patients with critical mitral stenosis, it is less than 1 centimeter squared. The indications for intervention should be individualized. All symptomatic patients require intervention, even with moderate symptoms. Asymptomatic patients with critical stenosis should be intervened upon. Additionally, patients with new onset atrial fibrillation and new development of pulmonary hypertension should have intervention. The medical therapy for mitral valve stenosis includes diuretic treatment, digitalis, and salt restriction. Surgical procedures for mitral stenosis include closed mitral commissurotomy, open mitral commissurotomy, and mitral valve replacement. A mitral valve replacement is likely with a thick anterior leaflet, a calcified valve, mixed mitral regurgitation and stenosis, and thick, short chordae. Percutaneous balloon valvuloplasty may be performed via transvenous and transseptal approaches. It is acceptable for uncomplicated mitral stenosis. It is obviously operator dependent. Contraindications to percutaneous balloon valvuloplasty include left atrial thrombus, severe calcification of the valve, severe subvalvular disease, and associated mitral incompetence. Surgical approaches to the mitral valve via a median sternotomy include Waterston's groove with detachment of the superior vena cava, a superior approach via the dome of the left atrium, transseptal, and transseptal biatrial. Additionally, a partial sternotomy may be performed. A right mini-thoracotomy may be performed, which is our institution's preferred method for isolated mitral valve operations. This includes less blood transfusion and a better cosmetic result. A left posterolateral mini-thoracotomy may be performed in the setting of multiple reoperations. A surgical commissurotomy through a closed technique does not require cardiopulmonary bypass. It involves finger fracture or transventricular dilator and is of historical interest only. A surgical commissurotomy enables one to evaluate non-pliable or calcified mitral valve. One can mobilize fused papillary muscles to correct subvalvular restrictive disease. One can effectively repair patients with mixed stenosis and insufficiency and remove left atrial thrombus. Mitral valve replacement may be approached via sternotomy, left thoracotomy, or right thoracotomy. It can be done conventionally with central cannulation or via a minimally invasive approach with either central or peripheral cannulation. Access can be obtained via a left atrial approach with an intra-atrial groove incision, a transeptal approach with a biatrial incision, or a superior approach with an incision in the dome of the left atrium. When considering a mitral valve replacement, one must choose between a mechanical or a tissue valve. The pathology of the valve must be considered, the need for anticoagulation, and durability of the valve. Examples of mechanical valves include the St. Jude Medical bileaflet valve, Starr-Edwards ball and cage valve, and the Med-Hall tilting disc valve. These have excellent longevity and hemodynamics. However, long-term anticoagulation is required. Examples of tissue valves include Carpentier-Edwards and Hancock porcine xenografts. These do have an increased late failure secondary to degeneration. However, there is no need for long-term anticoagulation. Mitral homografts are also available, and these may be appropriate choice in the setting of endocarditis. The results of medical therapy for mitral valve stenosis are equivalent to the natural progression of the disease. There is a 50% survival at 5 years, 34% at 10 years, and 14% after 20 years. Patients in New York Heart Association Class 1 at 10 years have an 85% survival. Class 2, 50% survival. Class 3, 20% survival. And in Class 4, none is alive at 10 years. Percutaneous commissurotomy has an initial success rate of greater than 90%. Some conclude that the long-term results of percutaneous commissurotomy are in fact equal to the surgical commissurotomy techniques. Patient selection was found to be of utmost importance. The open technique has a lower residual stenosis rate, lower recurrence rate, and increased freedom from reoperation. Commissurotomy results in excellent 15-year freedom from reoperation in the presence of isolated mitral stenosis. The current risk of elective primary mitral valve replacement is approximately 5%. The operative or 30-day mortality is related to myocardial failure, multisystem organ failure, bleeding, respiratory failure in a chronically ill debilitated individual, infection, stroke, and rarely technical problems. Mortality is correlated with preoperative functional class, age, and pre-existing coronary artery disease. Overall, better long-term results and freedom from reoperation when compared to both percutaneous and surgical commissurotomy.